Hello, I'm Gordon Caldwell. I'm a Fellow of the Royal College of Physicians of London, and I'm a consultant physician in the south coast of England. I want to talk to you about cardio-pulmonary resuscitation and clinical frailty. That's my GMC number there, and you can see my email if you want to email me to discuss this further. That's gordon.caldwell@wsht.nhs.uk. Now, I know quite a lot about cardiopulmonary resuscitation. I qualified as a doctor in 1980, and in 1983 I undertook this study about simple mechanical methods for cardioversion, defence of the precordial thump and cough version. This was a study looking at patients who'd had cardiac arrests at the Royal Sussex County Hospital in Brighton, some of them out of hospital arrests, and seeing whether doing a thump on the chest could terminate ventricular fibrillation or ventricular tachycardia. The study involved 248 people with ventricular fibrillation, 86 of those presented outside of hospital, and 68 with ventricular tachycardia. Now, on the right there you can see a claim, CPR saved my life, 50 survival stories, and it probably took quite a long time to get those 50 survival stories, because out of these 68 cases of ventricular tachycardia, 248 cases of ventricular fibrillation, making a total of 316 cases, just 15 of those patients survived to discharge. That's about 5%, or 1 in 20. And later on I'll be talking about cardiac arrests, and in cardiac arrests ventricular tachycardia and ventricular fibrillation are the most favourable rhythms, but also the least common rhythms that are seen during a cardiac arrest procedure. So overall the survival to discharge in all the cardiac arrests in that study would have been lower. So 95% of those patients that I was studying died having had CPR. Of course I can remember good events where doing a thump on the chest stopped ventricular tachycardia or reversed ventricular fibrillation and the patient recovered. But I have lots of really bad memories of those days. Mainly from the general wards. I can remember one ward at night time with an old lady like this, very frail lady, when the cardiac arrest team was called, and we worked on her doing full cardiopulmonary resuscitation for probably 30 or 45 minutes. In those days the resuscitation procedures were possibly even more aggressive. We used to put central lines into the neck, used to give potent drugs into the veins, a large number of different drugs, defibrillation as appropriate, and at the end of the procedure we'd always do intracardiac injection of adrenaline and then check to see whether there was a pericardial effusion that had caused the loss of cardiac output. And what I remember from those resuscitations on the wards is the feeling of the ribs breaking as we started doing cardiopulmonary resuscitation, the sternum breaking as well. Often the person then vomited, maybe they're incontinent of urine and feces, and at the end of the cardiopulmonary resuscitation the patient was naked and bruised and very undignified, and most of the cardiac arrest team would be in a state of near shock as well. And that convinced me of the clear need for what in those days was called do not resuscitate and is now called do not attempt cardiopulmonary resuscitation. I wanted to make sure that frail old ladies like the lady you can see there weren't subjected to futile CPR and have a very undignified, unpeaceful death, leaving everybody, patient, doctors, relatives, nurses, in a state of near shock. So when can cardiopulmonary resuscitation actually work? The top ECG there shows a hyperacute anterior myocardial infarction. This is coronary thrombosis, when one of the arteries to the heart gets blocked by blood clot. The muscle beyond that point will die, and as that process of dying is going on, malignant arrhythmias can be set off, which can cause a sudden collapse. So most people who suffer a coronary thrombosis, an acute coronary syndrome, a myocardial infarction, or in common terms a heart attack, suffer pain and death of some of the heart muscle. However, a small proportion of them develop these malignant heart rhythm disturbances, and the one in the middle that you can see here is ventricular fibrillation, and the one at the bottom here is ventricular tachycardia. So this is happening in the context of an acute myocardial infarction, or what's often called these days an acute coronary syndrome. There are other occasions when ventricular fibrillation or ventricular tachycardia can occur, and these are sometimes called primary ventricular fibrillation or ventricular tachycardia, or sometimes the scar tissue left after a myocardial infarction, particularly in a ventricular aneurysm, can set off rhythms like this. And so when is cardiopulmonary resuscitation started? I think there's some misunderstanding in the public eye and possibly amongst doctors about this. Cardiopulmonary resuscitation is started after a sudden death-like collapse at the onset of ventricular fibrillation or ventricular tachycardia. If the patient is standing, they'll collapse to the floor. If they're in bed, they become unconscious, and the person who's dealing with the patient will find that they can't feel any pulse. Particularly, they usually feel for a carotid pulse, the artery that supplies the brain, or the femoral pulse, the artery that supplies the leg, and there's no pulse, so the heart is not beating and pushing blood around the circulation. The patient at this stage is unconscious and cannot respond to their name, and their breathing has either stopped or is stopping. In common terms, the patient looks dead. So a sudden death-like collapse, and the patient looks dead before the treatment starts. Now I think again there's some confusion about what constitutes a cardiac arrest. In a cardiac arrest, the heart has stopped first. The heart pumps blood to all the other vital organs, and if the heart stops beating, the other vital organs will rapidly fail. So if you have a person who's fully fit and active and healthy, and the heart stops within 2 minutes, the brain will start to suffer irreparable damage, and the other vital organs, like the liver and the kidneys, will also sustain progressive damage. So the best outcomes for cardiac arrest occur in a coronary care unit. So a patient with an acute myocardial infarction, acute coronary syndrome, usually with intense pain in the chest, an ECG that might look like that one that I showed you earlier on, is transferred to the coronary care unit, is on a continuous ECG monitor, and if the rhythm suddenly deteriorates into ventricular fibrillation or ventricular tachycardia, the team of nurses and doctors in the coronary care unit can rapidly start cardiopulmonary resuscitation, very quickly defibrillate the heart if necessary, and try and reverse the situation. But even in the coronary care unit, when a patient develops ventricular fibrillation or ventricular tachycardia, the best survival is around about 50% of cases, and death in 50% of cases. So what proportion of people die of a cardiac arrest? In this picture I've illustrated that it may be a very small proportion of people who die of a cardiac arrest, as opposed to the other larger group of people who die of what I would call ordinary dying. In ordinary dying, the other vital organs have failed first, and then the heart stops finally. So the patient might have advanced kidney failure, advanced liver failure, and maybe even some cardiac failure with weakness of the way the heart pumps, and all the organs progressively fail, all the systems go down, and the heart finally stops as the patient dies. Whereas in cardiac arrest, it's the heart that stops first and is followed by the damage to the other organs. Cardiac arrest is the indication for cardiopulmonary resuscitation. Ordinary dying is not the indication for cardiopulmonary resuscitation, and it will not work, because all the organs are already failing and coming to the end of their viability. But even in a true cardiac arrest, the outcomes are much worse if health is frail. So if we're dealing with an elderly patient who's already got COPD, which used to be called bronchitis and emphysema, and maybe a degree of liver failure and renal failure, with some advanced cancer and becoming immobile, and then they have a coronary thrombosis, a heart attack, a myocardial infarction, and then develop ventricular fibrillation and ventricular tachycardia, it's very unlikely that we'll be able to resuscitate them. So you can see on the picture there some of the conditions which make somebody's health clinically frail, and if they were to have a coronary thrombosis, a heart attack, a myocardial infarction, complicated by ventricular fibrillation or ventricular tachycardia, it's very unlikely that they would survive. As I've said, most clinically frail people are at risk of ordinary dying, not of cardiac arrest. This is a study from Scotland looking at 10,743 patients who were inpatients in general hospitals on the 31st of March 2010. Of those 10,743 patients, nearly a third were dead 12 months later. So being in hospital is a risk for future death, and this makes sense. We know these days that the majority of people being admitted onto the acute medical wards are elderly patients with multiple problems and coming towards the end of their life. And in fact, for those patients who are 85 years and older, their chance of dying in the next 12 months was 45%. So most clinically frail people are at risk of ordinary dying, not at risk of cardiac arrest, because only a small proportion of them would ever have a myocardial infarction complicated by ventricular fibrillation or ventricular tachycardia, as well as the other clinical conditions they have. So in ordinary dying, there's progressive failure and weakness in many vital organs. The patient may have brain failure with a stroke or with dementia or transient ischemic attack. They might have heart failure with weakness of the heart causing breathlessness, COPD also causing breathlessness, liver cirrhosis, kidney failure, failure of the skin with pressure ulcers, all systems going down, and finally the heart stops. Now, as the heart stops under the circumstance where all systems are down, we can sometimes see some electrical activity from the heart called persistent electrical activity. For this reason, sometimes when patients who are brain dead and are on a life support machine and the life support is withdrawn, quite often the nurses and doctors would remove the cardiac monitor because this persistent electrical activity can go on for some time. It cannot be reversed by cardio-pulmonary resuscitation because this is all systems down, the heart has stopped. Even if we could get the heart restarted, all the other organs are in such a frail and terminal state that the person would be dead. So this comes now to the question of how do we recognise clinical frailty? And nurses are expert at identifying clinical frailty. These are the patients that are highlighted as risk of falls, nutritional risk, pressure sore risk, incontinence, people who need help with eating and drinking, and people who become progressively immobile. So maybe they can't walk to the toilet themselves, they can't transfer from the bed to the chair, maybe they're bedbound. They're very easy to recognise when they're admitted to hospital. Doctors are also able to recognise clinical frailty, but in my experience for some reason seem to deny the evidence for clinical frailty. And I try and get the doctors who work on our team to write a full list of diagnoses and comorbidities, because the greater you can see the list of comorbidities, the number of vital organs that are affected, then it becomes clearer that the patient is clinically frail. So at the bottom of this picture you can see the big conditions that undoubtedly lead to a condition of clinical frailty. So patients with advanced kidney failure, advanced metastatic cancer, respiratory failure from COPD, patients with liver failure and heart failure. So a heart failure patient may be breathless at rest, breathless just getting dressed. This indicates severe dysfunction of the heart. And then there are plenty of other conditions which are very common on our general medical wards, people with stroke, severe arthritis, transient ischemic attacks, less advanced cancer. I've put osteoporosis in there because the chest compressions involved in cardiopulmonary resuscitation are so vigorous that certainly in women over the age of 75, when we do those chest compressions, many ribs will fracture and the sternum might fracture as well. And it's known that rib fractures are serious injuries in elderly people. Combined with that, which doctors perhaps are less adept at identifying, is the reduction in functional mobility and functional abilities. So the person becoming increasingly housebound, can't walk upstairs, now is restricted to one floor at home, doesn't actually get out of the front door on their own feet any longer, takes to their chair, takes to their bed, unable to look after themselves, shop, cook, feed, nourish themselves, particularly if they're developing dementia as well. So between doctors, nurses, physiotherapists, occupational therapists, it's actually very straightforward to identify clinical frailty, and if we talk with our patients about it, they usually recognise that they've become old and frail and are approaching their end of life. So I think we've got into a dilemma somehow about the ethics of do not attempt cardiopulmonary resuscitation. This is very unfortunate, because going back to those cases I was telling you about at the Sussex County Hospital in the mid-1980s, I wanted to make sure that frail old people, or frail young people even, were not subjected to a degrading, brutal end of life, depriving them of calm, quiet passing away, maybe with their family around them. So when a doctor is talking about a do not attempt cardiopulmonary resuscitation, he's going right back to the ethics of medicine, which is first do no harm, and a keen desire to avoid undignified and brutal dying in frail patients. I could argue, and I think there is a strong argument, that cardiopulmonary resuscitation in frailty is futile and could actually be an assault on the body and unethical. If a person's been in hospital for 5 or 6 days and has been recognised as clinically frail, there would be plenty of time to explore with them what they would be thinking about with their future end of life, and most of them wouldn't be choosing cardiopulmonary resuscitation. So if we do it, if they suddenly collapsed and it's futile, we could be imposing a treatment on them without their consent, which was harmful and futile, and that doesn't fit with the ethics of medicine. So how did we get into this mess over do not attempt cardiopulmonary resuscitation, where doctors and nurses were wanting to protect patients from undignified, brutal death, and it's now almost as if we're under suspicion for saying that somebody is do not attempt cardiopulmonary resuscitation? One possibility is that just maybe the patient is dying of ventricular fibrillation or ventricular tachycardia and not of ordinary death. Well, if this was the case and we're postulating that the patient who's already clinically frail, maybe with advanced metastatic cancer or severe cardiac failure or severe respiratory failure, now we're postulating that in addition to that they have an acute myocardial infarction complicated by ventricular fibrillation or ventricular tachycardia. I know from experience and from the statistics that I've read that those patients do not survive cardiopulmonary resuscitation. At the very best, they might survive to get onto a life support machine in the intensive care unit and pass away on the intensive care unit. So in clinical frailty, even if it's a true cardiac arrest, it cannot be reversed. I think the other point that's led us to this dilemma is the do everything doctor. So it's common sometimes for a patient or for a relative particularly to say, you're telling me that my relative is very ill, very unwell, I want you to do everything, doctor, to make sure that he survives. But doing everything is restricted to ethical acts. Society expects and demands, and the law requires, that doctors recommend treatments that work and don't cause more harm or suffering than benefit. And we know that the relative actually doesn't mean do everything, because when the patient dies, in my experience, one of the first questions the relative asks is, but he didn't suffer, did he, doctor? So when the relative was saying the day before, do everything, doctor, he didn't say, do everything that doesn't cause unnecessary suffering, but he meant it. And when doctors talk about treatment and resuscitation, patients assume that this is something that's going to work. CPR, cardiopulmonary resuscitation in clinical frailty, won't work. So relatives, they say, are requesting do everything that does not cause suffering, doctor. And the reality is, in clinical frailty, particularly if the patient is deteriorating and heading towards death, is that we've been doing everything already and it hasn't worked, and the vital organs are failing and the patient is progressing towards end of life. George Orwell was very keen on precise use of words and understanding of meaning, and words are very powerful. So a doctor saying you are not for resus treatment sounds like we're denying you a treatment that will work. When doctors use the word treatment, patients assume it's something that will work. When they talk about resus, they take it to mean something that's going to resuscitate their lives, bring them back to life, restore them to full health. So if the doctor says you're not for resus treatment, sounds like we're denying you a treatment that will work. And what patient in their right mind is going to deny a treatment that will work? We've also got a much more complex situation with our hospital population. I see increasing numbers of patients who are elderly, frail and with multiple comorbidities. However, when they come into hospital, they may have developed a community-acquired pneumonia. We've got powerful antibiotics, and I'll be saying to the patient, you'll be going home in 3 or 5 days' time because I anticipate these antibiotics will work, and you'll get home, your health will still be frail, but you'll get better from this episode. The problem is that if that person deteriorates abruptly in hospital or slowly and somebody comes across them in a state of collapse, they wouldn't survive a CPR. So you're well enough to get better, but not well enough to come back from even a true cardiac arrest, let alone an inappropriate cardio-pulmonary resuscitation. And this can lead to very tortuous and difficult conversations with patients, particularly these days when 30% of our inpatients in general medical wards have dementia or delirium. I find it's quite often difficult for the patient to understand the diagnosis of pneumonia, let alone the complexities of you will be going home in 3 days' time, but should you deteriorate unexpectedly, we wouldn't get you back, so you're not for CPR. And I've even had a patient call me back after we'd gone through a whole consultation about pneumonia and asked her if there was anything she wanted to question. As we're leaving through the curtains, she called us back and said, "There is one thing I want to know. When am I going to die?" And I said, "Why do you think you're going to die?" She said, "Because at the middle of the night, one of the doctors came to my bedside and told me that I was going to die and I was not for resuscitation." The doctor was protecting this lady in case she had a relatively unexpected collapse or deterioration into death, wanted to protect her against cardiopulmonary resuscitation because of the current guidance from the General Medical Council and from the High Court. The doctor felt that that had to be discussed with the patient, and the patient was left with the thinking that she was going to die and that we weren't going to care for her. Another part of the power of words is that some people believe do not attempt cardiopulmonary resuscitation means no active treatments at all, and this is wrong. A person who is clinically frail being treated for pneumonia may warrant the best ward level treatment that we can give them, maybe even some other resuscitations, resuscitation with a blood transfusion, resuscitation with fluids, but not cardiopulmonary resuscitation. So do not attempt cardiopulmonary resuscitation. Very specific, means if you have a sudden death-like collapse or somebody comes across you and it looks like you've had a sudden death-like collapse, don't start doing the vigorous cardiac chest compressions that fracture the sternum, fracture the ribs. Don't go on to ventilation, don't go on to defibrillation, because it won't work. But all the other treatments may still be open to the person. I think as well, another bit around the power of words is to do with the quality of life. Doctors start talking about the quality of life. I'm very worried about that because I think sometimes they mean somebody like me who lives and thinks like I do must be a good quality of life. And very clinically frail people can live a long time and enjoy a high quality life. So you may be very clinically frail, but enjoying your family, enjoying reading, enjoying maybe doing even a little bit of gardening, and happy in your existence, but have very little quantity of life. And quality of life doesn't predict survival. I've heard many junior doctors say to me, "Oh, she's a lovely lady and she was playing bridge last night with her friends." That doesn't predict survival from cardiopulmonary resuscitation in clinical frailty. Quantity of life does predict survival, and of course doctors, being scientists, are much better at quantity of life. So if you simply add up the number of vital systems that are affected with disease processes in somebody, we can get some idea of how frail that person is. So a person who's had a stroke, has cardiac failure, respiratory failure, renal failure, a pressure ulcer, and is immobile, that person is clinically frail. As I say, the nurses, physiotherapists, occupational therapists, much better at identifying the immobility and the dependency that the person has developed. So recently I've been thinking that we should be moving much more away from the narrow, restricted vision of do not attempt cardiopulmonary resuscitation to recognition of clinical frailty and discussions around I want a peaceful death. If we could recognise clinical frailty, I think we could reduce much of the polypharmacy that patients are subjected to. For example, there's probably very little advantage in continuing statins in patients who are clinically frail. So we could reduce the polypharmacy. And with the patient and his relatives, we could be making plans for the time before and including end of life and how the person wants to spend that time. If we focus on do not attempt cardiopulmonary resuscitation, it really restricts our vision, and the doctors may just want to go for that, get the form signed and move on. Whereas an elderly, frail patient, I think, deserves much more attention, imagination, and working out of the last weeks, months before end of life, and what happens at the time of dying. And as I say, it's possible, I think, that cardiopulmonary resuscitation is unethical in clinical frailty. If we've recognised clinical frailty, we should recognise that cardiopulmonary resuscitation would be futile, and we should not practice it. I think you'll be hearing later on, the people who are going to hear this talk tomorrow, about ways that we could perhaps approach this with elderly people. I've been thinking you could say to people, you call me my doctor, and I recommend you request or even consent to a peaceful dying for your future end of life. So we could have a consent form for peaceful dying with the patient's pictures and ways of living, ways of dying that they would like to experience, if at all possible, as they come towards the end of their life. Or another useful way, I think, would be to say, from your mind's eye, paint for me a picture of your future ideal dying scene. When people have been asked those sort of questions or approached it in that sort of way, no one pictures dying from cardiopulmonary resuscitation, and particular doctors don't picture dying from cardiopulmonary resuscitation. Most doctors clearly want to die at home without very much in the way of interventional procedures. No one pictures dying on a life support machine as their way they'd like to die. So I'd say that if cardiopulmonary resuscitation is off canvas and dying on a life support machine is off canvas, why do we have to bring it into the picture and talk about do not attempt cardiopulmonary resuscitation? If a person has said the way they'd like to die is at home with their relatives around about them, peacefully, free of pain, free of breathlessness, why do we have to then explore the DNA CPR scenario? It doesn't make sense to me. So I would like to be thinking that for our clinically frail patient, we should be thinking of gentle care. Widen our thinking from the narrow, controversial do not attempt cardiopulmonary resuscitation to gentle care in Shakespeare's seventh age of man, the age of second childishness and mere oblivion, sans teeth, sans eyes, sans tastes, sans everything, and I would say, sans cardiopulmonary resuscitation. One way I've been thinking of this is the game of Jenga bricks, and as we get older, the bricks are slipped out from the bottom of the tower, making it unstable, whereas maybe when we're younger, the bricks are slipped out from higher in the tower. So we can think of a patient who's becoming increasingly immobile, has developed some incontinence, a degree of dementia, is beginning to lose weight, has a pressure sore, has had a stroke, then developing a degree of liver failure, kidney failure, respiratory failure, advanced cancer or cardiac failure, then maybe just something like a fall will bring the whole tower down. And a bit like Humpty Dumpty, once the tower's down, in clinical frailty, there's no way of putting it back together again. So I would say that the current position we're in with the do not attempt cardiopulmonary resuscitation is an intelligent kindness in clinical frailty. And it's us protecting our patients from an undignified, brutal cardiopulmonary resuscitation death. The Universal Declaration of Human Rights say that people should not suffer degrading treatments, and I think cardiopulmonary resuscitation is a degrading treatment in clinical frailty. Thank you.